wonderful session on the VWD guidelines and the points of shared decision making. We have two really fantastic presentations for you in store today, and it is my pleasure to introduce our first speaker to you, my very dear friend, Dr. Nathan Knell.
Thank you, Lena. And good morning, everyone, and welcome to this session on the VWD guidelines. And we're going to try to make this a little bit practical for you. And we're going to talk about how the guidelines were developed, the ways in which the bleeding disorders community was engaged in that process, and then talk a little bit about how we actually implement these guidelines and make them work for us on a day-to-day basis. And so my disclosures, as you can see, are up here. And I'm going to start with this image, and this is a stock image photo. If you go online and Google patient physicians or decisions, and you come up with this image of a physician or a clinician sitting with the patient and sharing information. And so this is an education moment of sharing health information, but it is one of these kind of typical images where there's a one-way exchange. And so the patient is sitting and listening, and it is a fairly passive process in most cases. And so this has been what medical care has been like for many years. But as we know, in the bleeding disorders community, we've been moving much more towards using shared decision making. When it comes to making a decision, all of us do all of these algorithms almost without even thinking about it. Our decision-making process starts from the moment we wake up in the morning and we're deciding, are we going to get out of bed? Are we going to sleep in? Are we going to hit snooze another time? What are the consequences of my actions? What are the alternatives? I could get up and I could go to the gym, or I can stay in where it's warm. And then those series of decisions go throughout the day for every single thing in which we're confronted. And our brain is processing all of this information and considering alternatives to the decision that we're probably going to make. What is the uncertainty in the outcome? What are the things? So if I stay in bed, what's the likelihood that I will get up on time to make it to work if the traffic is uncertain? What are the high-risk consequences? Things like, will my boss be mad at me? You then kind of think about interpersonal issues. All of this comes together, and we can apply these frameworks to health decisions and medical decisions. And I cannot think of a situation in hematology that is much more complex than thinking about bleeding disorders and all of the issues that come around making a decision about a particular product or choice or medical care. So starting off our session, we're talking about shared decision making. So how do we actually define shared decision making? This was kind of one of the seminal papers in the British Medical Journal in 2010. And it's an approach where clinicians and patients share best available evidence. That's a key part, best available evidence when making decisions. And patients are supported to consider options to achieve informed preferences. So out of this has grown an entire body of literature about decision making, and this has actually been applied in the bleeding disorders community and work before, which you'll hear about a little bit later. And so we're going to talk a little bit about how this affects us in the world of VWD. And why do we do shared decision making? Well, at its most basic, it's the right thing to do. It's ethically what we should be doing. When we think about ethical frameworks, autonomy, respect for persons, this is where we get into an individual's ability to control and choose what happens to their own bodies. This will reduce health disparities, and also shared decision making has significant improvements and impacts on the quality, the cost of care, and the value that is achieved in a healthcare system. And so not only is it the right thing to do, it's actually a good business decision. But the problem is, how do we implement it in the appropriate way? So I just put this up here. I always remember in medical schools learning about evidence-based medicine. EBM is what it was called. We hated the modules because of the way it was set up. But what we eventually realized is that evidence-based medicine is really how we go about achieving the best health outcomes. And I remember one of my senior physicians saying, we're going to move away from eminence-based medicine to evidence-based medicine. We're going to move away from, we're doing this because the physician told me I had to understanding this is why this is the best decision for me moving forward. So I'm going to talk and shift gears here just slightly to talk about our von Willebrand guidelines. And really, prior to the most updated set that we're going to talk about, we had guidelines in 2007 that were released by the NHLBI. These were based on an expert panel convened in 2004, and literature searches ended in 2006. And then these were published in late 2007. And so when it came time to update it, we were more than a decade out from the publication, and about 15 years out from the last set of evidence that was included. So this was a great opportunity. I really have to give credit to the National Hemophilia Foundation, who in 2014 held this strategic summit on von Willebrand disease. And this was one of the key statements that we used in a proposal to go back to multiple organizations to say, let's look at von Willebrand disease. And the NHF said a well-qualified or authoritative organization or consortium should develop new or updated evidence-based clinical practice guidelines on von Willebrand disease. So I'm fast forwarding through about 7 years worth of work and collaboration to get you to what actually was published last year. These two documents in the journal Blood Advances, they're open access, freely available to anyone in the world with an internet connection. And two separate guidelines, one on diagnosis of von Willebrand disease, and then the second one on the management of von Willebrand disease. When we came together now almost 7 years ago to say that we wanted to update these guidelines, we had some objectives in mind. First was that we wanted to facilitate clinical decision-making, essentially to create better health outcomes, quality of life, and health equity. We wanted to increase access to appropriate diagnostic testing and therapeutic options. We wanted to identify research priorities, and we wanted to guide healthcare payers and patients and providers as to what were the priority focus areas in VWD that should be key areas to implement in their clinical practices. This was a collaboration amongst multiple organizations. You see the 4 sponsoring organizations on the left, the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, and the World Federation of Hemophilia. And they engaged with the Kansas University Medical Center, Center for Evidence-Based Research to pull all the data that we could around von Willebrand disease over the last 10 to 20 years. What were the big updates and how should we adjust our clinical practice? The guideline development process is quite complex. We start with creating panels that are balanced of expertise. We had hematologists, both adult and pediatric hematologists on board, but we also had a dentist on one of the panels. We had obstetricians and gynecologists. We had individuals who were researchers that were primarily lab-based and individuals with pathology and laboratory medicine expertise. We made sure that we were paying attention to potential conflicts of interest, and this was done under confidentiality to make sure that the evidence would guide our decisions rather than potential conflicts of interest. Each panel came up with 10 to 20 clinically relevant questions. The common setup you'll see when we get to the actual recommendations of the question is what we call a PICO. We look at a population of interest, we look at an intervention and a potential other alternative, and then what were the outcomes for the patients. Then over a period of about a year, our evidence synthesis team went and searched literally hundreds of thousands of medical articles and extracted data on this to create evidence panels that would then be presented to the guideline panels for consideration. Just as a side note, all of these evidence synthesis work product was published in the last year. 5 of them are in Blood Advances, and the Prophylaxis one, I believe, was just published in Hemophilia. And so we have quite a bit of evidence out there now to then guide future research. And then finally, the panel comes together and makes the recommendations. And this is another schematic view of how the guidelines come together. And you see all these different pieces working in this flow. But the most important thing you see at the middle is the panel. So what were our panel compositions? Who did we pull together to do this? Well, first, we needed to know what were the priority areas that we were going to try to cover, and what did the community actually need. And so we decided to send out this international survey. It was developed and disseminated by the partner organizations. And this ended up being the largest survey of patients and caregivers with von Willebrand disease ever. And it covered 71 countries across 6 continents. We had 600 participants. And then amazingly, we got over 9,000 comments. So these were not just the people are clicking yes or choosing on a scale of 1 to 10 how important this is. People were putting individual comments into different sections and saying, this is really important for this reason. And so we started pulling all this information together to help us decide what we were going to choose as our questions. The guidelines, once they were in draft form, also went out for public comment response. We had 38 countries represented, and 15% of these came directly from patients. When we published the guidelines, we had these strong versus conditional recommendations. A strong recommendation is usually backed up by randomized controlled data. You may have heard from Dr. Valentino in the one of the last sessions talking about heart failure trials with 40,000 patients in it, and we don't have a lot of that. And having randomized controlled trials in bleeding disorders is actually really tough to implement. And so oftentimes we wouldn't have the strength of evidence that would be applied if we were asking a question in cardiovascular disease. And so a lot of our recommendations end up in this conditional category, which meant for patients, a majority would want the intervention, but many would not. And importantly, for clinicians, different choices may be appropriate for specific patients depending on preferences and values. And this is a specific call out to shared decision-making in the implementation process for the guidelines. We took a high resource setting. We knew that we would eventually need to adapt these guidelines to different regions of the world with different resources, but we decided to say, in an ideal situation, knowing the evidence that we know now, what would be the standard of care? What should we do? And this would inform advocacy efforts and policy work, knowing that even here in the United States, there's a lot of variability in how VWD care is performed. Our patient panelists were full voting members, and so very early on, we made a decision that everyone was going to be on a first name basis because everybody was an expert in their own area. And so we would talk about patient experts and lab experts and clinical experts, but everybody was considered an expert when we would send out emails, and everybody used everybody else's first name to make sure that the panels came together. So we had 2 panels, one on diagnosis, and this was a photograph that was taken during the initial group getting together. And what I love is that we took this photo and then it had to go into like a sealed archive because we were doing this and nobody was aware of the panel composition outside of the organizations. We also had a separate panel for management, and there's some of us that sat on both panels to provide coordination. So the guidelines and diagnosis cover use of bleeding assessment tools, laboratory tests for diagnosis, how to approach individuals who have levels that change as they age, and use of genetic testing. And then the management talks about prophylaxis. This was actually the first prophylaxis recommendation in VWD to be published. Use of desmopressin, surgical management, and then gynecologic and obstetric management. So I want to dive for just talking about shared decision-making into one of the specific guidelines. So this was the prophylaxis recommendation. This was recommendation number 1 in the management guideline. And here was our PICO question. So our population were patients with VWD and a history of severe and frequent bleeds. Our intervention was routine prophylaxis, and our outcomes were a number of bleeding events, and this was separately detailed in the manuscript. And the recommendation was that in patients with severe and frequent bleeds, the guideline panel suggests using long-term prophylaxis rather than none. And this was a conditional recommendation based on low certainty in the evidence of effects. And so you'll see that the word suggests is italicized there. Every recommendation says either recommends or suggests. Recommends was a strong recommendation. Suggests was a conditional recommendation. And so how did we get from that question to that recommendation? And so there's our recommendation. And we had 3 bodies of evidence in the medical literature that started the foundation of discussion. The first was one randomized clinical trial comparing prophylaxis to placebo. This was actually amazing. When we told our methods team, do not expect to find randomized controlled trials in von Willebrand disease, they were very excited to email us and say, we have one. We have one that we're going to talk about. And so this was included. There were also some retrospective observational studies looking at different time periods and different types of comparisons that were done. So we ended up having all of these studies that they condensed the data and brought it together for us. And so overall, the evidence showed if we offered prophylaxis, it reduced the risk of bleeding, it improved time to first bleeding event, it reduced epistaxis, that was clear from the study, and it reduced the risk of bleeding episodes, hospitalizations, and bleeding. Now, one of the problems is the randomized controlled trial actually had an increase in types of bleeding lasting more than 2 days and increased GI hemorrhage, which is odd, doesn't make sense. If you're giving somebody prophylaxis, why should they have more bleeding? Well, we started to dive down into the clinical trial and we realized that the majority of these events happened in one patient. And so while all of the tools that we used to gauge these studies said that there was imprecision in the effects, the panel was able to sit there and say, we believe the randomized controlled trial. We believe that this is beneficial, and that if this one individual had not been in this study, or a different individual had been in this study, we may not have seen this, or it may have been a stronger effect. And so from there, we justified and we said, while there's a low certainty in the evidence, it appears that there's a net health benefit. And there were very large costs associated with prophylaxis. Because if you think about it, if you're only using factor on demand, you're going to end up with potentially lower factor costs. But are you actually going to be sacrificing the costs that you would pay for hospitalization? And so there is all of these trade-offs that had to be considered. And there were actually at the time no formal cost effectiveness analyses available. But the panel said long-term prophylaxis is likely to be acceptable and feasible and to increase equity. And so this was the understanding, talking to the patients that were part of our guideline panel to understand what would be the effect of prophylaxis. Diving down, if you go into the guidelines, you can dive deep into every single domain and section that we were considering. And so I pulled this out from our evidence decision table, that what were the values that might affect our ability to implement prophylaxis? What might somebody say is their decision points? What are they thinking about? Well, one, we may notice that somebody who has more frequent and severe bleeds might gain more value or see more value in use of prophylaxis than somebody who has bleeds but says that it's not as bothersome for them because they're not as frequent. The age of the patient may play a role in making decisions about prophylaxis. Many times it's not the patient themselves who would be administering the prophy, it's their family members or other caregivers. And we noted that patients with higher bleeding rates were likely to place higher value on preventing episodes. So if you don't have a lot of bleeds, you may say that doing all of this and sticking myself multiple times a month in order to give myself prophylaxis isn't actually beneficial, because what, I'm going to prevent maybe 1 or 2 bleeds, as opposed to somebody who says, I'm already having multiple bleeds and I'm not having a great quality of life. And this was a specific call out by one of the pediatric hematologists and one of the patients on our panel, that educational materials would be key. And as an aside, the methods chair for this was actually not a hematologist. She was she's a nephrologist by training, and she actually just stopped the panel one day and said, "Explain to me prophy. How would you explain prophy to a patient?" And you would hear people saying, and there's all this stuff, and she's like, "All of you know it, but what if I'm at home and trying to learn and figure this out for myself?" And this was all of a sudden this light bulb that went off, and we're like, we really need to work on the education materials. There were representatives from NHF and WFH and ISTH and ASH in the room, and they started taking notes and saying, this is going to be a major point of our implementation and dissemination efforts once these get published. So I want to end on this kind of image, 2 images again of, how do we get to our ultimate outcome? Our outcome is better care for people living with VWD. And on the left, you see an image where someone is being brought up and helped, but they are doing the work to get there. And this is very directed, probably by the individual on top who is giving them the directions to go. And on the right, you see this team, a coach who is working together as part of an entire team so that they move together towards a common goal. And I see that's really what we're doing in the HTCs and the clinics, and coming together with patients and multidisciplinary care to implement a plan that's going to be what provides long-term health outcomes. So just some acknowledgements. There were a number of individuals who were involved in the guideline development process. My clinical and management co-chairs are listed up there. These were the staff liaisons at the time from the different organizations. And we had our scoping panel and guideline panelists. I also want to point out that some of these slides are available online on the ASH website as a teaching slide set around VWD, and those were created by Kristen Maher and Chris Eng. And so at this point, we're going to finish there, and I'm going to turn this over to Dr. Folland.
So while we are bringing up the next slide, thank you first and foremost for a great presentation and recap of the VWD guidelines. So for those of you who have attended VWD pre-con, we talked a little bit on this whole concept of people being partner, of the people who are actually living with VWD, being a subject matter expert, and for everything that we are doing, really being for the community, with the community. And that's exactly what the development of the VWD guidelines was, and what it will be continue to be. So it was a process that included the subject matter experts. So it was not a top-down approach where you had a group of physicians and scientists sit together and come up with some recommendations, but it really included the subject matter expert, the person who is living with VWD and who can really enlighten all of us on what it is like, what you are going through, what is important to you, what we need to tackle in the clinic, and what we need to focus on. So where we are going from here is really how we're going to implement this, how we're going to let all of you know about the guidelines, but how we're also enabling you to utilize these to help you to get the care that you need, and how are we helping our healthcare providers to implement these in a clinical setting. So that's what we're going to go through in these next couple of slides here a little bit more. So I have nothing to disclose besides, obviously, you know by now that I work for NHF, but I did want to provide a little bit the lens that I'm often applying, because I think that's always important that we're kind of pointing out from what angle we are tackling this discussion. So some of you have heard before, I started out as a physical therapist, and I started out in chronic pain management, nothing to do with bleeding disorders at all. And then by some magical coincidence, I landed in an HTC and fell in love with this community, with all of you. And then also what is important here too is I'm a translational health scientist. So I look at problems a lot through with complexity science. So I love big, complex issues with many layers. I love looking at health systems, and I love implementation and dissemination science. So that's a lot of my background too. But you've heard this before, I'm the director of education at NHF. But most importantly, I'm also a mom. So those are my 3 daughters who are at home right now. So as many of you, I have a family too. And while they don't have bleeding disorders, they have a lot of SAS. So here we are. So you know a little bit more about me, but we're here to talk about shared decision making. And obviously, you are a partner of this. And I think that is the big change that we are going through. Historically, we had this paternalistic model, right? Where you had your healthcare provider, and your healthcare provider will tell you what to do. They will tell you what medication to take, what plan of care to have. And then we really moved forward. And a big push happened actually with the Affordable Care Act, with this being put into legislature, where it was said that the patient, so the person who's living with the disease, has a right to information. So this is written into the law and into the regulation that the person who has to make a decision on what treatment plan to take has the right to know everything about it. That is informed decision making. So what the model that developed from there was essentially that the healthcare provider would provide all of the information about the different options that are available, and then you would make a decision on what you wanted to do. Now, shared decision-making is a little bit more of a team approach. So what happens in shared decision-making is that the healthcare provider would pretty much outline all of the information. They would give you the different options. They would allow you to find out about the pros and cons, and then you would aid in your information. So you would add to that conversation what your personal values are, what matters to you, what matters to your family, what matters to your spouse, partner, to your children. And it becomes a team approach. So then we are putting all of this information together, and together we can make a decision on what the best plan of care is for you. Because there's not a one size fits all, and there are many, many different shades of gray. And we need to put all of this together to make a decision of what will work for you. Because the treatment plan that might work for you might not work for you at all, and it might be completely different for you. So we need to put your life circumstances and what is important to you and what matters to you into that equation. But how are we going to do this? So I wanted to introduce a framework that I personally like very much, and that has been employed in a lot of the clinical settings. And Dr. Valentino and Mark Skinner have written a really great article on this too, which is the SHARE approach. So SHARE stands for seeking participation, for help explore and compare the different options, assessing the values and the preferences, reaching a decision, and evaluating that decision. So SHARE, seek, help, assess, reach, and evaluate. So this is the framework we're going to talk a little bit more about. So seek is really that first step. So seek we're doing to really let everybody know that we need to make a decision, that there is an option. So we're really needing to come to that mutual understanding that we need to have a discussion about the different options that are out there to put a plan together that is right for you. And this is really that open invitation to having a discussion. But I want to put some food of thought in here too, because shared decision making is not right for everyone. There are many people who might not feel comfortable being involved in that decision making, who are overwhelmed, who culturally might not have experienced this before, and that is okay. That is also a decision to not be involved in that. And I want that to make clear so that not everybody needs to participate if they don't feel comfortable to do so. So help is that next component, and this is where we're working together to assure that everybody is clear about the risks and the benefits of the different options. Let's say we are, for example, deciding between two different treatments. So we got an outline of like, these are the risks and these are the benefits of each. So we got to really make sure that this is unbiased and that there is a clear understanding. This is also a great opportunity for you to be involved. And this is where we are developing some great decision tools to really talk somebody through the different options that are there. We are currently in the process of developing shared decision-making tools for several of the recommendations in the VWD guidelines to really have something in hand and talk about it. I think the other really big, important food for thought that we often forget is that not making a change to the current treatment is an option as well. Maybe you're proposing something new as a healthcare provider, but then maybe you, as the person with the bleeding disorder, you're completely happy with where you are at. And that's okay. And that's okay to say. Now, the next one is the assess, right? So now this is where you are so vital, where you are so important. This is where you are sharing your values, your preferences, and what matters to you. So this is also where you can bring in your family, your spouse, partner, somebody who is important in your life, somebody who knows you, somebody who might be able to help you make a decision. If we're talking about a child, obviously this is where parents are involved. The other part though, have you ever heard of a decision-making coach? No? So some clinics and some universities now have these wonderful people that will actually help you figure out what is important to you. So this goes beyond your healthcare provider. Often this is a social worker or somebody who is specifically trained, and they will actually sit down with you after you have had a discussion to really talk through the different options and finding out what matters to you. So there's an additional outside person who will support you. So some of the clinics have these people now. So, but this is really about you and what matters to you. And then we are getting to that reach component, right? Eventually we need to make a decision. And that decision can be that we're not making any changes, that we are changing to a different treatment plan, that we are changing a whole plan of care. And it's okay to take some time. That decision needs to be made between you and the healthcare provider. That is a team approach. But it is also okay to say, like, you know what, this is great information. Let me go home and actually read it. Let me go home and think about it a little bit, and I will get back to you. Let me go home and talk to my family about the different options that I have. And that's okay. That is completely okay to do. It's also okay to find a second opinion if you seek so. Eventually, though, we need to come to a decision point, right? If we are making a decision about our plan of care, eventually we need to make one. And that's when we really need to evaluate then too. So we've made a decision, we have employed our plan of care, and this is where we often fall short. And this is something so vital though to this shared decision-making process. We sometimes need to go back and reevaluate. Was that change that we made, that decision what we made, was that the right decision? Or did we make that decision and now after a couple of weeks, after a couple of months, we're figuring out that maybe that was not the right path for us. So it's always fine to go back and have another discussion about this and making changes if we need to be. Okay. So you need to consider your overall well-being. So if something was changed in your plan of care and it is not working for you, it's okay to speak up. It is okay to talk to your healthcare provider again. Say like, you know what? This sounded like a really great idea when we were talking about it, but now that we're doing it, isn't working so much for me. So can we change something again? And that is so vital to have that communication and to keep that communication going and to really then reiterate what you need. Because remember back that wonderful picture, Janelle's shout here, where you had that team approach. That team approach goes through the treatment and through your plan of care too, right? We are a team. It is not just one person dictating to the other. We are a team throughout the entire process. And this is really that framework that we are using to implement shared decision-making, especially with the VWD guidelines. So remember, share approach, right? That is often helpful. So I wanted to take a look a little bit at some examples from our VWD guidelines. So some of the recommendations are not necessarily lending themselves to a shared decision-making approach, but some of them really need to include your voice, because some of them are especially conditional recommendations where it matters of what is your value, what matters to you, what is important to you, because both decisions would be great and they would be fine. So one good example is this one. This is from the diagnosis component. And this recommendation stated that the panel suggests reconsidering the diagnosis as opposed to removing the diagnosis for patients with previously confirmed type 1 VWD who have VWF levels that have normalized with age. That's a mouthful. But what that essentially means, as we are aging with VWD, our factor levels might actually rise and increase. Now, if you have type 1, that can bring you above the threshold where you would be considered having VWD. So what that also means, in that moment, in the past, your diagnosis would be removed. What that also means, when your diagnosis gets removed, think about access to the treatment center, think about other issues that you might still be having, right? So what we have in the guidelines now is that we will have a discussion about this. So let's say your levels have increased, and let's say you are now above the threshold where you would be considered having VWD. We can have a discussion now about this if you really want to have your diagnosis removed or if you want to keep it. And that really depends on you and what matters in your life and what your life experiences are. So let me give you two different scenarios here. I'll explain this a little bit more. These are real life situations. So let's say you're a young man with or a younger man with VWD. You've never had any symptoms and any really big experiences, and your levels are rising, and you say like, okay, I don't have any symptoms. I have never had any issues. I don't need this diagnosis. So then it can be removed. Let's say you are a person with VWD who has had significant issues, frequent bleeds, and so forth. And now you're reaching that threshold. In the past, it would be removed. But now you can say, you know what? I'm still having symptoms. I have had these bleeds throughout my life. I'm still having issues from these bleeds. I still want to make sure that I get access and the care that I need. I would love to maintain my diagnosis of VWD. Okay? So it really matters of what is important to you. It's your opinion, your values that we will include in that decision. So we will have a shared approach. We will have a discussion about it. We will invite you to have that discussion, right? Share, we'll talk about the pros and cons, helping you understand all the benefits and the risks with it. We will then really assess what matters to you. We'll reach a decision, and then eventually we'll reevaluate, make sure that decision was right for you. So this is one of the recommendations in the diagnosis guidelines where shared decision-making is absolutely vital. Remember, we are a team. We're in this together. We are supporting each other, and you are the subject matter expert. So I want to share another example with you, which I think is such a beautiful example that I really want to mention here. So this is from the management guidelines, and these recommendations 6A and B. So I'll read them out very quick, and then we'll talk about them a little bit more. So the panel suggests using either hormonal therapy. So here we're talking about hormonal contraception or an IED, or tranexamic acid over desmopressin to treat women or people really with VWD with heavy menstrual bleeding who do not wish to conceive. So those people who have the potential to menstruate who don't want to have a baby right now. 6B says the panel suggests using tranexamic acid over desmopressin to treat people with VWD and heavy menstrual bleeding who wish to conceive. So if you would like to become pregnant, if that is in your plan right now, hormonal therapy wouldn't really be the best situation for you right now. But I really want to point out again, we are using hormonal therapy for treatment in VWD, which I think is really important in the realm that we are talking and in our world right now. It is something that we're using, but it's important of what are your values? What matters to you? We have different options here, and all of them are fantastic and great. They all have their risks and benefits, but it's you who needs to be included in this discussion. Your personal values need to be included in this discussion. So then we can make a decision on what you should be on. Should you receive hormonal therapy, and then also which one? Or should we go the tranexamic acid route? So it matters again of what is your life looking like right now? And what values do you have for yourself and your family? And how do those align with the different options that are there? So again, we will have a share approach, right? We will have a discussion about these different options. We will help to really understand what the different risks and benefits are. We will assess what matters to you, then reach a decision, and then reevaluate if that is really the right decision for you. So these are two really great examples that are from the recommendations for VWD that are so vital for that shared decision-making approach. There are a couple more in there, but these are the ones that I really wanted to point out for you. And why is this so important? Why is it important that we're talking so much about shared decision-making? Because it is not a new concept. So it's becoming this buzz term right now, because obviously we have the VWD guidelines, which include this a lot. We're talking a lot about gene therapy, which also includes a lot of shared decision-making. But the concept of shared decision-making is not new. It has been around for multiple decades. And we always say like, oh yeah, we're doing this. Of course, like we're talking in the clinic, right? We're having these discussions, but there's a big discrepancy. And this is a really great study that was done a while ago in people with bleeding disorders, which really found that patients and healthcare providers differ in their experience, perception, and belief regarding shared decision-making. So a lot of the healthcare providers would say like, oh yeah, we totally did that. We totally had that conversation. And then when you talk to the patient who was in the room, was having the same discussion, their experience was completely different. We're saying like, yeah, I don't think we had a really good discussion about this. I don't feel like we discussed the different options, and I'm not sure really what to do, right? So the big differences were really about the frequency of shared decision-making engagement that was there, how often this was actually truly accomplished, how patients felt that they were included. It was different in regards to treatment goals and quality of life. There was a lot of difference there too, as well as treatment-specific information, including the risks and benefits. Very often, the healthcare providers believed that they really laid out all of the risks and benefits, but when they talked to the patient on the flip side, they found out that they didn't perceive the same thing. They didn't feel like they had received all of the information that they truly need to make a decision. And then really the progress towards treatment goals and what the endpoint should be and what the goals should be. So there's a discrepancy between our understanding, and this is why it is so vital to continue this conversation about shared decision-making on both ends, so that we can have this wonderful team approach and this mutual understanding. So when we're looking further into the literature on bleeding disorder, there's unfortunately not a lot. There's a lot more out there outside of bleeding disorders, but the most research that we currently have is essentially focused on treatment choices in gene therapy. So that is the biggest focus right now or the realm that we're talking shared decision-making about. And there's very limited evidence in regards to any shared decision-making tools, anything that would really support us in that process. So there are a couple of articles there that I just wanted to briefly mention. So there's a lot of work that we still need to do. So even though shared decision-making has been around for a long time, we haven't really included it and investigated it deeply. And it's so vital for our overall implementation of the VWD guidelines. So with this, I really would love to have a discussion with all of you more about your experiences, your questions, and where we really go from here. I want to remind everybody that we have the ability to fill out evaluations online rather than the paper version. There are the QR codes on the table there and there, and we will pull up the slide again too. There's also a raffle, so make sure you fill these out. They will help us plan in the future too. But what I really want to do next is have a good discussion here and take all of your questions. I also wanted to second. So in case you're interested in the VWD guidelines and want to see the different recommendations, we have these wonderful resources that we created, which include on both sides the recommendations broken down. So the purple one are the diagnosis recommendations that are all there. And on the flip side are the management recommendations for the VWD guidelines. I have them up front here. You're more than welcome to take them with you if you are interested. So they are there for you. And then again, remember that you are the subject matter expert. You are the person who's living with VWD. Your healthcare providers are the technical experts. And all of that knowledge needs to come together because everybody brings a different lens, a different perspective. But when we are combining that, that's where the beauty can happen, where we can create plans that work for you and where we can all be included. So remember, everything is with the community, for the community. Okay, so with this, we would love to take your questions. One, two.
Within the recommendations for both of you, is there something that talks about like some of or most of us, obviously we got here, so we have someone behind us that tells us that this community exists. I live in Pittsburgh, so I have really great hematologists around me. And if I took these recommendations to them, they could look at them and definitely use them as a tool to make my treatment plan. In these recommendations, or does it teach us as consumers, how do we get our physician to advocate for us? Because we know that if I go in with one type of insurance and you give me two different choices, hey, you could take this or try this, and I want to try this particular plan A, but my insurance formulary is different. They're not going to pay for this. You haven't tried this and failed on this yet. How do we teach each other or help each other advocate for that and say, you know what, Dr. Lena, I really, like I know that you can call and do a debate with another physician at the insurance company and things like that to try to get the plan that I want. How do we get physicians, because some people don't go to hemophilia treatment centers. They go to a hematologist or their PCP is managing it. So we take these recommendations, which are probably fantastic. I can't wait to read them all. But how do we convince someone that obviously is more educated than us, but sometimes we have more knowledge on our bleeding disorder than the person that's going to be prescribing our treatment? I don't think so.
Okay, let's try that. There we go. So thank you for that question. I think that gets to a very broad set of issues, not just in VWD, but in bleeding disorders and all of healthcare. And if we had an answer to that, we wouldn't be in the state we are right now in the United States with our healthcare system. But there are a few things. One is that we had many more questions and things we wanted to address than we could in the guidelines. However, so the recommendations, the specific questions are very focused on clinical issues, and we would make statements being very cognizant that what we said might affect insurance coverage. And so, for instance, we were very careful to say VWF concentrate and not say a specific product. And so because we didn't have information to, at that time, recommend plasma derived over recombinant, we included both. And we then made a specific call saying that future research needs to look specifically at differences between plasma derived and recombinant VWF in outcomes of heavy menstrual bleeding and GI bleeding, or combinations of therapies. We did that very specifically, understanding the policy implications and the coverage implications. So that was one aspect. The second thing that we did in the guidelines that we wanted to weave in there, even though it wasn't part of traditional guideline methodology that the American Society of Hematology had used, but we used some of the frameworks that WFH and NHF have used in their guidelines and in MASAC guidance documents, was thinking about essentially the term for them are these good practice statements. These are things that you should do that really you don't need an evidence search to go after. You know, as a hematologist, I don't need a guideline to tell me if a patient with VWD has anemia, work up the anemia. I don't need a recommendation in order to justify that. So one of the guidelines, one of the good practice statements we made is that patients with VWD should have care delivered in a coordinated multidisciplinary fashion whenever possible, using the model of the HTC. Now, is the HTC model right for everyone? No. Even in my own practice for years, many of my VWD patients haven't been in an HTC. But when it is appropriate, that's where really the care should be delivered. And I think, you know, Lena and I talk about this all the time about joint health in VWD and use of physical therapy in VWD, which has not traditionally been there, and do some changes in my own practice. Many of my VWD patients have moved into our HTC and are meeting our physical therapist and actually learning about preventive health. What preventive measures can they take? Again, these are all things that care delivery can be there. I think the next step is this dissemination and implementation effort to get to the point that you're bringing up of how do you advocate. You work with your local chapters and you work with the staff of your HTC or your treatment center, and you advocate to get to care where you feel like you're getting good care. That may be delivered in, you know, your primary care's office or a general hematology office. Can I tell you how many OBGYNs in my own system are now screening for VWD? Like, it's crazy, because I've sat there and I've talked to all of them multiple times about it, and they've started realizing, wow, all of this bleeding is not just anatomic. There's VWD, so it requires ongoing education.
I just wanted to add a little bit to that in regards to that. I have to step there because of our virtual folks so that they can still see me. So hold on a second. So I just wanted to add to that NHF and ASH are working a lot on the dissemination, which includes training too. So, and that training is not just for hematologists. Obviously, we like to include, especially the hematologists who are not working in HTC settings, so our community providers who are seeing a lot of other disease states too. But I think the other level here in regards to education is educating our primary care providers, as they are often an access point, our OBGYNs, as they are often an access point, but then also thinking about colleges, right? School health, people in school settings, right? They need to have that education too, because very often they are the first person who might be in contact with that person. So it's really aligning then again with decreasing the path to diagnosis along the way and really understanding these guidelines a little bit more. So there are a lot of educational initiatives going on many different levels as well. Also want to point out, just to add to this a little bit more, but one thing our policy team was working on is really working with the insurances. They are pushing forward some changes in the ICD coding right now, and they are working closely with the insurances, especially on to really push the prophylaxis part. The recommendation one from the management guidelines to really push that forward. So there's a lot happening on our end to really implement these, and not just implement them by letting you know about them, but really implementing it on many, many, many different levels to allow you to get the care that you need. Other questions?
Thank you. It's just an addition, because I'm from WFH, and yesterday at our booth, a man with VWD came and he looked, the guideline were on the table, and he said that he asked for treatment to be covered by his insurance, and the insurance refused. But then when he got back to the doctor with the VWD guideline, they decided to cover it. So exactly. So I think that's really proof that true.
Thank you so much for sharing that. So I have heard people, oh, I need to go there again, sorry. I'll learn this eventually. And that's not a single story. So I have met people too who have actually taken the guideline document and showed it to them. And be like, look, this is the guideline. This is the care I should be receiving. And that is something that you can do too. Also, if you have significant issues with your insurance or so, your hematologist might be able to help, your HTC might be able to help, social worker, but you can also contact us at NHF. So we'll be happy to support you too. So please know that we're here for you. Other questions? Comments? Sure. We have 4 minutes. Okay. Well, just as a reminder, and can we please pull up that evaluation deck again? Please, please, please do me a favor. Fill out the evaluations. Again, there is a raffle, so you can actually win something. So that's a good thing too. It's your guys' slide deck. There's also paper copies here if you want to scan it in there as well. You can. It's not on that slide deck, but it's here too. I'll leave it here. So there's a raffle, and you will help us also make sure that we are providing education that matters to you. And again, remember, we are one team. We are one community. And what we're doing is with the community, for the community. Thank you.